Hello, my name is Brian Higgins. I'm currently a student with Capella University working on my Master's of Science in Nursing degree. This presentation is designed for students who are attending a nursing program and studying the disease process of Tetralogy of Fallot. This presentation will help guide them through the first 12 years of a child's life. Tetralogy of Fallot affects 3 out of every 10,000 live births worldwide and makes up approximately 7 to 10% of all births with a congenital heart defect. While there is no direct correlation, Tetralogy of Fallot has been associated with untreated maternal diabetes, fetal ketonuria, or a genetic disorder that affects protein synthesis, and intake of retinoic acid. Retinoic acid is often used with cancer patients and is an ingredient in some wrinkle creams. These are the only modifiable risk factors to prevention of tetralogy of Fallot, which makes pre-screening and prenatal care an important part of prevention. Those who do not or cannot afford health care then are at greater risk, such as those who live in third world countries where health care is difficult to come by. Tetralogy of Fallot is also frequently seen in children who have trisomies 21, 18, and 13, but a direct cause and effect association has not been proven. Tetralogy of Fallot affects children regardless of sex or nationality. Approximately half of all cases of tetralogy of Fallot are diagnosed before birth. The severity of the disease can be assessed, and then surgical or non-surgical interventions can be planned. Tetralogy of Fallot can be diagnosed by an ultrasound as early as 12 weeks of gestation. Most children require surgical correction between the ages of 4 and 6 months of age. After birth, tetralogy of Fallot can be diagnosed by either chest x-ray, which can show an enlarged heart, or an echocardiogram, which can show electrical conduction changes related to right ventricular hypertrophy. The definitive diagnostic tool for diagnosis of tetralogy of Fallot is an echocardiogram. This test can show the severity of the disease and assist with planning treatment and surgical interventions. What is tetralogy of Fallot? Well, tetralogy of Fallot is actually 4 different conditions that affect the heart. The first is an overriding aorta. The aorta is the major blood vessel that comes off of the heart and carries blood out to the body. It is shifted from its normal position over the left ventricle, and it's moved towards the middle of the heart. The second condition is pulmonary stenosis. Pulmonary artery is the blood vessel that carries blood from the heart to the lungs to get oxygenated. This narrowing of this artery prevents blood from getting to the lungs. The third condition is a ventricular septal defect, which is a hole in between the bottom 2 chambers or ventricles of the heart. These all combine to cause right ventricular hypertrophy. Because of the pressure contained on the left side of the heart and that ventricular and due to all 3 previous conditions, the right side of the heart has to create more muscle tissue to try and compensate for the other 3 conditions and the increased pressure that's in that heart. So that side of the heart, the right ventricle, is thickened or become hypertrophied. Treatment options vary based on facility policies and practice. Most surgical interventions are delayed until the infant reaches 4 to 6 months of age. Occasionally, an infusion of prostaglandin will be administered. This will help keep the foramen ovale open to assist with perfusion. If this fails to maintain adequate oxygenation, then an aorta pulmonary shunt can be placed to help increase the amount of blood that reaches the lungs for oxygenation. Once the child is aged and is determined that the child has optimal survival from surgery, then a complete surgical intervention is done. If surgical intervention is done, children often do not require repeated surgical interventions within the first year of this life, but this does not ensure there is no need for more surgeries as the child ages. Children who do not require immediate surgical intervention can often have TET spells. When under stress, like stooling or crying, the child's demand for oxygenation will increase, and because supply cannot keep up with demand, the child becomes cyanotic. The first intervention is to correct the problem. such as changing the diaper, comforting the child, feeding the child, but also pushing the knees up to the chest. What this does is it helps to create or increase systemic vascular resistance and increase systemic venous return to the heart. This increases right ventricular preload and increased blood flow to the lungs. Supplemental oxygen should also be given, and occasionally subcutaneous morphine can help decrease the heart rate along with decreasing the release of catecholamines. These two combined help to increase right ventricular filling, thereby increasing the amount of blood that can be pumped out of the right ventricle and to become oxygenated. If all of these fail to reduce the TET spell, the last resort is to medically paralyze the infant and have the infant intubated. What I have presented here is just a basic concept map for a patient who suffers from Tetralogy of Fallot. In the next few slides, we will cover a few nursing diagnoses that can follow along with this concept map. Remember, each concept map and subsequent nursing diagnosis should be tailored specific to each patient. They can change as the child ages, day by day, even hour by hour. These can help serve as a guideline for planning your own patient's care. First is ineffective tissue perfusion. Those who are born with Tetralogy of Fallot are at a greater risk for developing pulmonary artery hypertension. Due to these high pressures in the left side of the heart and the right ventricular septal defect, the pressures in the right side of the heart are also increased. This increases the pressure on the pulmonary arteries as well, which these increased pressures can cause remodeling in these arteries, which further increases pulmonary artery vascular resistance. Often these children, as they age, and even as infants, they can display some dyspnea with exercise, fatigue, peripheral edema, chest pain, and syncope. In a study conducted by Martins de Silva et al., there were determined 4 qualities that indicate ineffective airway clearance in children with congenital heart defects. These indicators were adventitious lung sounds, sputum production, changes in respiratory rate and rhythm, and restlessness. Of all of these indicators, the best and most specific indicator was adventitious lung sounds. While restlessness was considered statistically significant, these patients are often in the hospital and recovering from a surgical procedure. Because of this, they are often sedated, and it wasn't clinically significant because of the medications given to the patients. Risk for injury related to increased risk for thromboembolism. These children are an increased risk for developing a thromboembolic event. Due to their hypoxemia at birth, these children often have an increased hemoglobin level and an increase in their hematocrit. Coupled with a decrease in platelet production, these children have thicker blood and are more prone to clotting. When you add in the decreased activity due to sedation and multiple surgical procedures, this further increases the risk to develop clots. Hopelessness. This slide tends to focus more on the family, as the infant really doesn't experience hopelessness, but due to the family having to deal with this disease, I added this in here because the patient needs to be treated as a whole, and the family is part of that patient's treatment. So while these children have to survive from a serious medical condition, the health of these children affects the entire family. The first thing that affects the family is that the birth of a child is a normally joyful time and but instead it is now filled with hopelessness and the fear of the potential death for their newborn. Often, one parent feels as though they have to stay at the bedside and act as protector to their child, which can cause them to neglect their other roles within the family, such as being a parent to other children, a partner to their loved one, or could even cause them to give up a potential source of income. With frequent and long hospitalizations, along with constant supervision at home upon discharge, the family can begin to feel the strain of isolation from friends and other family members. Impaired physical mobility. As these children age and recover from the multiple surgical procedures, they begin to grow and develop into young children. These children, while appearing healthy, often have difficulty keeping up with their peers, needing frequent breaks and having difficulty breathing. They can find it hard to keep up with friends, and they may often find themselves socially isolated from various games and activities. These children are born with a life-threatening condition, and the first hurdle is helping the family to cope with the changes that affect them. These children have to undergo various surgical procedures to correct their congenital heart disease, often within the first couple years of life. These nursing diagnoses should act as a guideline for those who work with these children, and this is by no means an all-inclusive list. As the family and child grows, the needs and nursing diagnosis need to grow and change with them. Here is a list of my references. If you have any questions or want further detail, feel free to look up these articles in my reference page for more information.